Okay, let's get started. So, hi everyone. I'm David Huang, the president of the International Ocular Circulation Society, and I'm at the KC Eye Institute in Portland, Oregon. I want to welcome everyone to the first IOCS Retinal OCT Angiography case conference. The purpose of this conference is to promote this new imaging technology by demonstrating its various clinical uses, and two, to harmonize the interpretation of OCTA internationally. So this conference is geared towards those in the Pan-Pacific time zones. It's more convenient for people on the American West Coast and in Asia. I promise we'll have another one that will be more convenient for those in Europe and on the East Coast after this one. This session will be recorded, just to be legal. I want to let everyone know. And I'd like to thank Dr. Steve Bailey and Thomas Hwang for organizing this session. And I want to thank Dr. Motohiro Kamei, Dr. Shih-Jen Chen, Dr. Andre Romano, Dr. Min Wang, and Dr. Yuichi Ogura, who's going to be the next IOCS president, for being on the panel as moderators. And I also want to thank Jessica Malum, who's our IOCS administrators, for organizing the all the logistics and putting everything together. Jessica, do you want to say hi first, and then we'll turn this over to Dr. Thomas Hwang and Steve Bailey.
Hi, everyone. We've been chatting. Thank you for coming.
Thomas? Or Steve, rather?
Hi. Hello, everyone. This is Steve Bailey from Portland, Oregon, KC Institute, and we're going to open up our first block of presentations. Briefly, these are case conferences, and we're trying to emphasize using new OCTA technology to help us interpret, diagnose, and manage these cases. And this is a clinical conference, and so we're really encouraging audience members to use the Q&A box to ask questions if they have them during each presentation. We will leave a presentation. We will have a discussion after each case where the group of panelists and the presenter will be asked questions. And if you have those, please use the question and answer function. The chat does not work, so it's important that you use the Q&A box, and we'll be monitoring that. We'll try to get all of the questions we can in the amount of time that we have. This is a live conference. And so there will be a little bit of a handoff or a transition between each presentation. And so we sort of have about a minute or so potentially in between each presentation as we switch to each presenter. Thank you for being here today. And we'll get started here with our first presentation, which is Dr. Jiuan Sheu, presenting hidden CNV and inflammation tissue. And so we'll begin the screen sharing now.
Hi everyone, I'm sorry I didn't know the format, but I suppose it's a case presentation. So I just going to show a simple case. The name is hidden CNV in inflammation tissue. This is a 20-year-old lady who is the Aboriginal high school college student. It was systemic cases, and systemic workup didn't show anything. She was referred to me when because she has a visual impairment in the right eye for 1 year and the left eye in recent 2 weeks. We can see the choroidal retina scar with some inflammation margin, and there's more severe, more pigmentation in the right eye, but not but less in the left eye. Anatomic OCT in the right eye show the fibrosis and the choroidal retinal atrophy and some high refractive material, and the OCTA clearly show the choroidal neovascularization. But for the left eye, we can see just outer segment destruction and some inflammation. But in OCT, it's very tiny hyperfluorescence. You cannot tell whether it's CNV or not, but it's highly suspected when according her complaint. And for the fluorescent angiography, we can just see the staining and leaking from inflammatory tissue. We cannot tell the exact location or the nature of the hyperfluorescence. For this, for right eye, it seems quite compatible in the choroidal CNV tissue in this area. But for the left eye, we just see the hyperfluorescence here, which is difficult to tell. But this 1 week, just out of 1 week, although it's a prominent CNV in the right eye, and unfortunately, this kind of CNV did not fit the reimbursement criteria for in our insurance, and she is not willing to pay for herself in the right eye. But unfortunately, in the left eye, the vision dropped very quickly from the initially is 0.8 in this time, and then dropped to 0.3 in this time. In after 1 week, you can see the very prominent CNV at this high point. She agreed to receive the intravitreal injection of Idea. Since the rapid course, I also add oral steroid for her. And this is 3 days after injection, we can see much decrease of the CNV tissue. And during this period, we have more, we have treated right eye for 3 times and left eye for only 2 times. And after a very short course, about 2 months of oral steroid, and start with megadose and the tapering. And this time point, you can see the vision in both eyes are both improved. From this case, I think OCTA is more sensitive in detecting and monitoring the CNV in uveitis patient, and is from the early stage of this patient, it's much more sensitive and useful, because for OCTA we can repeat in a short time during our clinical visit, but not fluorescent angiography. So this is a case of choroidal neovascularization secondary to punctate in the choroidopathy, and successfully management by intravitreal anti-VEGF and monitored by OCTA. Like other uveitis-related CNV in PCV is sometimes difficult to be detected and measured in FAG. So OCTA had the advantage of 3-dimensional view of retina and choroidal tissue without interference by dye leakage or staining. Thank you very much. A very short case. I'm done.
Great. I have a quick question for you. Do you feel that, are you treating based on changes in the CNV size with anti-VEGF if you see it growing? Some of these cases, don't have a lot of intraretinal fluid or subretinal fluid like we see with macular degeneration, for example, which we typically use as biomarkers. Do you see the size of the CNV changing with OCTA helping you determine maybe immunosuppression or when to do an anti-VEGF over time?
Yeah, I do. But if just for one eye or the course is very slow, I may not add the oral steroid. I use steroid when I think that it's quite active and in progression, like this lady. And I also check, of course, this case, the anterior segment is silent. If they in other uveitis, when we have combined more side of the inflammation, usually add the steroid or immunosuppressant if necessary. Or I think anti-VEGF is just for CNV, but the CNV is not the only needed treatment in uveitis related CNV. We have to depend on the inflammatory status of this case, because if there is inflammation and CNV, you have to treat both. If you treat only CNV part, the course will never end. That's what. Is it okay for you? My answer?
Thank you. Yeah.
Yeah.
Hi, can I ask the question? Jun, it's a very interesting case. Thank you for presentation. This is Kamei from Japan. Have you tried FAG after your treatment? I'd like to know how different between the pre-treatment and after treatment in FA.
Oh, yeah. But
what is the difference?
I can say, if I repeat, I didn't forget. I forget whether I have FAG. I think I have, maybe after 1 year. We can tell, like we always say, it's a backward guard. We can tell the intensity of the fluorescence may be less, maybe not so fluffy. That's the part of CNV, like the old scar, more like that. But it's less difficult than the OCT to really quantify the change of the size of the CNV. That's what I feel about it. FAG is still important, maybe in the diagnosis and the follow-up, but for now, I won't routinely do FAG. I think choroidal thickness is also very important when you're monitoring the uveitis with CNV, because choroid thickness, the change in choroid thickness is sometimes more sensitive than the clinical part. It comes before the really dominant recurrence of something. That's my answer. And do you have any comment about this issue? I also like to know your comment. I think this kind of case is also common in Taiwan and Japan.
Yes. We have a similar case, and when we see the patient, I check the very early stage of the FA and also after the middle or later phase of the FA. So we are check the leakage in FA. But so we can say that the status or activity of the CNV. What the time of the FA you showed in the picture, the present slide? What time? Do you remember?
I think this is left phase about, I think it's about 60 seconds. I agree with you. We check the early phase, middle phase. We actually did all the phase, but I show the left phase. I agree with you. We check clearly the early phase, the middle phase, the change of the timing and the intensity of the leaking will be also helpful. But for the patient, I think they will prefer to do OCTA, and in our clinic, maybe you know our the schedule is very full. When you want to do the FAG on the same time, it's sometimes difficult. So, but we can do the OCTA on the same time, so we can make a decision of the diagnosis or treatment quickly, especially when patient lives far away. This patient come from more mountain area, remote area, so we can make decision right away and make things easier. Yeah.
Great.
Also, can I ask one more question? That the lesion is scattered between the posterior pole to the little bit wider area. Do you check all the spots or all the lesion? Any CNV occur?
Yeah, I used to, in uveitis, I used to do wide field image, FAG.
Not only FAG, OCTA.
OCTA is impossible. We can only check the
Macular area.
We can only check the macular area. Even I think some of the lesion is really outside our case. Our machine cannot detect it. Maybe the new one, the design one in Japan can do it. But in some uveitis, the lesion is very, very far away. So I don't think any on market OCTA can do it. I think OCTA cannot replace FAG for nowadays, but maybe sometime, but not now. We still have to rely on the multiple image to make the diagnosis and treatment for our patient. But I really expect to have the wide field OCTA. So maybe one day we can just do quick shot to do all the ocular circulation in a patient in a very short time. Yeah.
Great. Thank you, Dr. Sheu. We'll be moving on now to the next speaker, Dr. De-Kuang Huang, who will be presenting using OCTA to rule out CNV in a patient with choroiditis.
Thank you, Stephen, and good morning. Hi, everyone. Actually, my case is just quite similar with Dr. Sheu, and that I think OCTA is a very useful tool in uveitis. To make the presentation in time, I'll use the pre-recorded video. Let me share my screen. Hi everyone, this is De-Kuang Huang from Taiwan Taipei Veteran General Hospital. My case today is about using OCTA to rule out CNV in patients with choroiditis. This is a 58-year-old female complaining about acute visual scotoma in her left eye. She has been diagnosed as myopic CNV in right eye and treated with anti-Vegf injection for 3 years. At the presentation, her visual acuity was 6/30 in right eye and 6/15 in left eye. A process of anterior chamber cells and anterior visual cells were noticed in her left eye. During the last 2 years, as you can see, there are many punctate choroid retinal lesions progress in her right eye, as well as a few new lesions in her left eye. FAG revealed many hyperfluorescence lesions, and in ICG you may find many dark spots, and some of them are not correlated to the found color or FAG. Her right eye OCT revealed subretinal hyperrefractive lesions, and in left eye you may find some submacular epsiloid zone change. The OCTA in right eye showed a vascular network in outer retina and choroidal capillary layer. So the patient was diagnosed as bilateral PIC with secondary CNV in her right eye, and we gave her systemic steroids and peribulbar decadron therapy. With the therapy, the condition improved and stable within 4 months. However, she suffered from acute visual decline in right eye again, and the reactivation of CNV was diagnosed. After anti-Vegf and subtenon-triamcinolone therapy, the lesion improved and became dry, with the visual acuity back to 6/60. So we gradually tapered her systemic steroid and discontinued it after 16 months of therapy. However, 1 week after we DC her steroid, she suffered from acute scotoma in left eye again. As you can see, there are some new subretinal lesions appeared. To rule out the possibility of CNV, we performed the OCTA again. Fortunately, there was no sign of CNV, but only some hypoperfusion lesion in choroidal capillary layer corresponding to the lesion. So we added back the oral steroid and inject the subtenon triamcinolone. After 1 month, you could see the subretinal lesion subside, and her visual acuity recovered to 6/6 gradually. However, when we tried to discontinue the systemic steroid again, this time the choroiditis recurred 3.5 months later. Again, the lesion improved after oral and subtenon steroids. Even when we tried to add the mycophenolate for several months, the choroiditis still recurred again after a few months after we discontinued all medications. And this time, you could notice that even there was no subretinal lesions in cross-line OCT, there was still a new paramacular suspect CNV lesion developed in her left eye. And this time, we've tried to inject the anti-VEGF and subtenon steroid alone, without systemic medication. Unfortunately, although her vision improved a little, and the possible CNV lesion became unclear in OCTA, there were still some subretinal lesions developed. So we could only add back the systemic steroid and do the subtenon injection again. The patient is still undergoing therapy and follow-up still to today. In this case, we highlight the utility of OCTA in uveitis, which is to observe the perfusion change in retina or choroidal capillary networks, and also to detect and follow up CNV secondary to uveitis. As you may know, CNV is one of the important ocular complications of uveitis, especially choroiditis. In some cases, it is really difficult to distinguish whether the CNV was primary or results from high myopia or secondary to underlying choroiditis. Sometimes multimodal images are needed. On the other hand, OCTA is one of the most useful images to detecting CNV, such as this case, or inflammatory lesion in uveitis, such as this case. In summary, we demonstrated the usage of OCTA for detecting CNV in uveitis patients, and it could be used as a guide for treatment options. Thank you.
Thank you.
Thank you. Great presentation. One question, with OCTA, do you feel that you see the CNV typically completely regress after sort of a single anti-VEGF injection, or does the CNV tend to linger longer?
No, most of the time when a CNV develops, it usually cannot regress completely. So, such as this case in her right eye, finally we choose to use a fixed interval anti-VEGF injection to control the secondary CNV. But when the lesion was just came out, as soon as possible, when you use steroid and anti-VEGF, sometimes it could be regressed, but the recurrence rate is very high.
Dr. Kamei, do you have a question?
Dr. Huang, can I ask you, do you think these reluctant cases with PIC recurring so many times, is that related with her high myopia?
I'm not pretty sure that some people suggest that PIC is a form of multifocal choroiditis in high myopic population, and which means that some etiologies between PIC and multifocal choroiditis were just the same, but the appearance was similar in high myopic patient. And in this case, I don't really think that's became from a rule of high myopic in this case, since the choroidal thickness is not as thin as that myopic CNV patient in our clinics, other myopic CNV patients which have very, very thin choroid, and these patients have relatively thicker choroid than high myopic patient.
I have a question from the audience. This is from Dr. Brandon Lujan. He is asking, do you feel confident ruling out CNV on OCTA with the present outer retina and choroid capillaris labs, or do you actively use the software to look for evidence of CNV?
Pardon, could you ask the question again?
Do you feel confident ruling CNV in or out with OCTA with the image generated by the software, or do you use the software to look at different slabs to confirm that you think CNV is there or not, depending on, so how do you use your OCTA to confirm it or rule it out?
Yes, I usually use the automatic segmentation of the machine because in my clinic, I don't have much time to adjust layer by layer for that. But I think in most of the time, I could find the correct lesion in that patient.
Can I add more? Can I add more?
Sure, we have time for one more quick comment, then we have to move on.
Can I add more? Can I ask?
Yes.
Do you think the change, or I also ask the panel, do you think the response to anti-VEGF for CNV secondary to PM of uveitis, when they get old, the response difference, their response were more like AMD? Because in my case, it's very younger, since response quite good, and this case older, and so maybe different, or I also answered to the other questions. So for PIC combined with PM, it's better to do segmentation by yourself, because sometimes the contour it's difficult to do accurately by auto segmentation.
I agree with you, and I think is there any panel want to give the comment of that?
My interpretation is that as they get older, there may be more ischemia, so the CNV may act more like an AMD patient. So that would sort of be my interpretation of that. Okay, to keep moving here, we're going to move on to the next presenter, which is Jiuan Ding, who will present CNVs in children.
Okay, thank you. Yeah, please quickly the sharing, the screen sharing. De-Kuang?
De-Kuang 把那个分享关掉。
Okay, it's okay now. Okay. So, can you see my slide? Yeah. Okay. So, you just mentioned, so if a CNV happened in a young patient, what will be happen? So today I would like to share with you the CNVs in children. Okay, so we all know in the older population, AMD and PCV, especially PCV, is very common. In Asia, about 60% is PCV, and the etiology underlying is aging. How about the type? The majority is type 1 CNV that is sub-RPE predominantly. So today I will talk about CNV in children or teenager. Here is my case. This is a girl, 11 years old. The BCVA is quite good in her right eye, but only 20/60 in her left eye. Very interesting, this girl is diagnosed as optic neuritis for 3 years, and she also got systemic steroid for about 6 months, but nothing happened. So what will we do next? What will we do next? OCTA? Because we are talking about OCTA today, but of course not. In this case, I give her a FAF, autofluorescence. So this is a very, very critical examination in this patient, because this picture told us it is a Jiuan, an optic nerve Jiuan. It is very easy to misdiagnose as a neuritis. Okay, here is the Jiuan. But I believe the real juicing is much more than this one, because most of them are buried. They are not, perhaps not shown on the FAF because it's too deep. Okay, so optic juicing. Here is the OCT. The macular in her right eye is quite good and remarkable, but the optic nerve is elevated. And here is what we can see in her left eye. Here, the protruded optic nerve here, and the juicing is buried very deep. I believe it is here, and the outlier in the fovea is discontinued. I think it is because the duration of this lesion is so long, and there was some liquid under the macular spaces, but now it is gone. But the outlier is not so good. That's why her vision is decreased. And here is a CNV. It is a peripapilar CNV associated with the juicing. And here, OCTA is not so good because there is no slab can cover both optic nerves, the elevated optic nerve, and the CNV. So it is not so good. But I think here in her right eye, the right eye and left eye, these vessels is at the surface of the optic nerve, and here this one is from the CNV, and this one on this B scan, it is very, very helpful, even helpful than this C scan. Okay, the buried juicing is here, and here you can see the CNV. The RPE is disconnected, and there is some signals of the flow, but not so much. And the lesion here, the CNV is very high. It is very hyperrefractive. Okay, here we can see the FFA. It is confirmed as a CNV associated with the optic juicing. It is active. Okay, so final diagnosis is now changed to the CNV associated with optic juicing. And we can see the elevation of the disc, blurring of the disc margin, increase of the size of the, it is showed if the size of the juicing increase, there will be more CNV. It's very interesting. The juicing is there from the girl was born, but the onset age is ranged from the 7 to 14. But the majority of the children with the optic nerve juicing will have CNV ranged from 9 to 12 years old. And in this kind of patients, I tried some. They need more injections than those subfoveal lesions. And I also have a very quick case 2 to show another case in pediatric CNV. Here, this is also a girl of 16 years old. The BCVA is not so good, so he has no myopia. The features is very clear, it's unremarkable. So when you diagnose it with an idiopathic CNV, so OCT show it is active, there is some liquid, and this one, it's very active. But FF here, it is active, the early phase and the late phase. But at the peripheral retina, it is shows there is a lot of vasculitis. So the final diagnosis, we changed it to intermediate uveitis. How about the CNV in children? Actually, we have a case series about 32 patients. And here is the etiology analysis. We can see the etiology is very diverse. There is a lot of reasons we can induce a CNV in children. And here I have a picture shows there. There is only about 1/3, 30% is idiopathic, but a lot of it is associated with congenital conditions such as persistent fetal vasculature, CHRRPE, juicing, and morning glory disc anatomy. That is very different from that in adults. And here, if we want to compare the CNVs in children with that in adults, we can see the majority of the CNV is type 2, that is subretinal in children, and the location, the majority is a peripapillary, but not under the fovea. The size is very small, the maturity is very high. There is always a lot of fibrosis that is very resistant to the anti-Vegf therapy. And if the CNV is peripapillary, they need more injections. Thanks.
Thank you. That was a great case. How confident are you in using OCTA to make the diagnosis without FA? And are you getting high quality scans in children that allow you to do that so you can maybe avoid using FA?
Yes, it is depends on the etiology. If the CNV is at the macro area, and it is quite easy to get, because if the children is under 4 years old, we use the sedation, so that's no problem. But if the CNV is at the peripapillary, that is very difficult, because it will be covered with the PFV, the lesions from the PFV, the lesions from the CHRPE. But remember, the majority of the CNV in children, in my case series, that is located at the peripapillary.
And in the cases with optic dystrusion, do you feel the CNV really gives you, or the OCTA gives you more confidence because you can actually see the flow in the CNV?
Yes, of course.
Can I ask a question?
Yeah, of course.
丁教授你好。
Oh, yeah.
Yeah. Good lectures, and I have 2 questions. The first one is for the first case. Did you find the feeding vessels for CNV? And what's the relationship between the optic disc drusen and the CNV? And the second question is for both cases. And I just read your papers on the type of CNV on OCTA. Can you describe the type of CNV on OCTA for both 2 cases? Thank you very much.
The type of CNV, right?
Yes,
okay.
yes.
Yeah, for your first questions, you asked it is a CNV or atrophy. I'm very confident it's a CNV because to a case with optic nerve drusen, CNV is one of the most common complements of this disease, and we also employed OCTA to show very good the flow in the lesions. So it is not because of the atrophy. Okay, so for your second question about the type of the CNV, the majority of the CNV in children, they are type 2. Type 2, so that is a very typical CNV. It's subretinal, but in front of the RPE. So that's type 2. Thank you.
Thank you.
Bailey, can I have one more question?
Go ahead.
Okay, Shou-Yan, very good case. Can you tell us what's the correlation between the buried optic nerve drusen and the CNV?
I don't think so. The type of juicing, it is buried or it is at the surface of the optic disc. So if there is some difference between 2 subtypes of these drusen, but you know, we only have several cases. It is a rare disease, rare condition. So I'm not confident about this, but it is not reported. So I think the size and the volume of the drusen is correlated with the rate of the CNV, but so not the subtype.
Okay, thanks.
We have one question from the audience we'll try to squeeze in. The question is, why does the CNV in the peripapillary retina need more treatments than the CNV around the fovea?
Okay. I think it is also related. It is correlated with the etiologies, the underlying reasons of the CNV. So in PFV, so that is a disease of optic disc. So some CNV in PFV, in CHRRPE, such kind of CNV, they always located at the peripapillary. But you know, the underlying reasons, we cannot resolve the PFV. And the condition is always there. And there, I think they are because of some chronic inflammation. So inflammation is always there. So I think that's why they need more anti-VEGF therapy. The response is not so good if we compare with those submacular ones.
Great, that makes sense. Thank you.
Thank you.
Okay. Our next presenter is Dr. Yi-Ting Hsieh, presenting OCTA findings in congenital looped coiled peripapillary retinal vessels.
Hi, good morning or good afternoon, everyone. It's nice to see you all here and hope we can meet in person later this year. And previous speakers have talked about CNV, but now I'm going to share something different. This is congenital loop coiled peripapillary retinal vessels. Maybe many of you are not familiar with this term, and we have published this kind of disease 15 years ago. To describe it briefly, it is an anomalous vascular loop or coils, and they are part of the main retinal vasculature without protruding into the vitreous. They mainly are part of the artery, but some also involve the veins, and the vascular patterns usually are stable over years. They are symptomless until some of them have retinal, preretinal, or vitreous hemorrhage, but the hemorrhage are usually localized, and they are secondary to the bloodstream turbulence and the vascular torsion. Here is one more exaggerated example. We can see that many looped, coiled, patterned vessel here, and we see it clearly. We can see that they are part of the original retinal vessels. So the vessel come up from the optic nerve and from the loop, the coil here, and then go normally. So if we look at the FA, we can see that there are no leakage from the FA. And for example, this patient appeared in the clinic because she had some sudden onset of floater. We can see that there are some hemorrhage here. And because of the turbulence in the coil, so sometimes they may have such kind of localized retinal hemorrhage or vitreous hemorrhage, but they are usually benign and have the spontaneous resolution. And we have followed up these patients for more than 20 years. And we can see that the vascular pattern are all stable. What I have to differentiate is the so-called congenital prepapillary loop. It is different because such kind of loop is not part of the main retinal vasculature. They usually rise into the vitreous and form one or more twists and then return to the vessel on the optic disc. In this kind of case, some severe complications have been reported, include retinal artery occlusion, hyphema, amaurosis, fugax. But in our cases, in the so-called congenital loop coiled peripapillary retinal vessels, we have collected more than 20 cases, and none of them have such kind of severe complications. So what's the correlation with the OCTA? Okay, let's see a case presentation here. This is a 42 female who present with the new onset of floaters. We can see that in the left eye, there are some vitreous hemorrhage. So where did it come from? It's come from the looped vessel here. And we think it is the so-called peripapillary coil looped retinal vessels. And we can see from the OCT that these vessels are within the retinal layer. They do not protrude into the vitreous. So when we see from the FA, yeah, we can see that the vessel, they do not leak. They just form the loop, the coil here, and then go along normally. But it is interesting because we also performed OCTA in this case. When we see the abnormal vessel here, but how about in the OCTA? Yes, we can see there are some coil loop here. But besides this kind of vessel, we can see that it seems that not only the loop coil here is abnormal, we can also see some abnormal vessel here. If we look at another layers, we can also see that not only here, but also here. These are not typically seen in normal population, this kind of vessel. What about the right eye? We cannot see any abnormal vessel from the color fundus or FA, but when you look at the OCTA, we can also see some abnormal loop here and here. So this kind of vessel can only be seen in the OCTA. So from the OCTA, actually, I'm not so sure that if they are part of the normal vessel or they are just isolated from the normal vessel. So the so-called loop coil peripapillary retinal vessel and the pre-papillary vascular loop, maybe they are belong to a spectrum disease. They are not a totally different disease. And OCTA may reveal more abnormal retinal vessels than the color fundus and photography and FA do. We still don't collect many of the OCTA image from this kind of patient, and we'll try to collect more from them and see if there are more interesting images. Thank you.
Thank you. Beautiful presentation. I guess I have more of a comment. It would be neat to do more OCTAs to see if these are more often bilateral, than we would have thought otherwise, because that's a very interesting observation.
Yes, a very beautiful case, Dr. Hsieh. Have you ever tried unfast OCT to see those coiled or looped vessel? I mean, in terms of projection, unfast OCT.
Yes. When performing the OCTA, we also obtain the unfast OCT, but actually the image is not that clear as the OCTA do. So I didn't show it here. Yeah,
okay.
To see the vessel more clearly, we need the OCTA.
All right, thank you.
Okay, looks like we're ready to move on. Our next presenter is Dr. Tai-Chi Lin. We'll be presenting on OCTA in the differentiation of pachychoroid disease.
Thank you. Thank you for giving me this opportunity to talk about the use of OCTA in pachychoroid diseases. Okay, I'm Dr. Tai-Chi Lin from Taipei Veteran General Hospital. So putting down the correct diagnosis for pachychoroid disease is sometimes challenging. So investigators, they intend to use different clinical features on OCT to make the correct diagnosis. So let me show you my case. This is a 64-year-old female who complained metamorphopsia in the left eye. So when she came to my clinic, the vision in her right eye was 6.6 and 7.5 in the left eye. So I hope you can appreciate the subretinal fluid here, seen on the fundus color. On the OCT, you see the subretinal fluid with these hyperrefractive deposit down on the OCT. So I was really old-fashioned, and my thoughts are very straightforward. My initial impression was CSC, although the age doesn't match, and she's not a smoker, and she doesn't have any other systemic diseases. So I performed fluorescein angiography for her, and you can see the pinpoint leakage here. And in order to speed up the recovery of the subretinal fluid, I performed a focal laser PC for her. So 1 month after the focal laser, her vision remains the same in the left eye, but you do see the decrease of the subretinal fluid here. So I let her go home and keep on observation. However, 3 months after, her vision worsened to 6.10 in the left eye, and then it is now difficult to say whether these leaking points still have active leakage, because since I already performed laser to it, this could just be the staining of the fluorescent on the previous laser spot. But I still gave a little bit addition laser PC for her, and then 3 months after the second laser PC, her vision decreased to 0.5 in the left eye, and the dramatically changed on the OCT presentation, as you can see here, with this PED and the bubble sign down here, and with some increased subretinal fluid. So my impression now is PCV. So again, on ICGA, it is relatively difficult to tell that whether these are polyps or it could just be the staining on the previous laser spot. So finally, OCTA came to my mind. So I performed an OCTA here, and clearly we can see the neovascularization and the vessel branching network in the choroid level. So it confirms the diagnosis of PCV. So I gave her 3 consecutive intravitreal injection of Eylea, and you can see the change of the OCT here. And then the resolution of subretinal fluid and the improvement of PED 4 months after the 3 consecutive injections. However, another 1 month later, you could see PED again, and then 2 months later, the subretinal fluid here. So I performed another OCTA showing that these neovascularizations are still here with a little bit recurrence of the subretinal fluid. So I gave her further addition injection of Eylea. So 1 month after the 4th injection, her visual acuity returned to 6.75, and with a resolution of subretinal fluid. So another OCTA was performed, although the vessel still stays here, but it is relatively silent and inactive right now. So in my conclusion, pegychoroid diseases are sometimes difficult to distinguish. And in my case, performing FA or IC, if you did not perform the OCTA in the very first step, doing ICG and OCT and FAG may be misleading because you have already performed laser to the RPE. So at this time, using OCTA is a useful tool to distinguish where there's NV or not, and will help you to make the decision making for whether giving the intravitreal injection or not. Thank you.
Great job. Do you think there was CNV initially on that first presentation?
Yeah, I think it's high possibility because sometimes we know sometimes in pegychoroid patients, even though the initial presentation, it's likely to be CSC, but there might be some NV in the very initial stage. So yeah. I guess that explains why sometimes these patients responded to anti-VEGF.
Mm-hmm. And sometimes if that PED is there with that irregular sort of bumpy appearance too, sometimes that makes me a little suspicious.
Yeah,
so.
That's correct. Yeah.
A very good case, Dr. Lin. For my experience, if this patient visit in my clinic for the first time, when I noticed double layer sign on the OCT, I would do OCTA first. And if I want to treat the patient as CSC, I would prefer to do PDT instead of single spot laser. That's my experience.
Great, thank you.
Dr. Kamei? Oh, Dr. Kamei, unmute yourself. Dr. Kamei, you're muted.
Hi, the Tai-Chi, the very nice presentation. Did you stop the anti-VEGF treatment at the last visit? Is that right? You
yes.
Didn't inject?
No, I didn't give the injection. Yeah.
Well, why? How do you evaluate the activity of the CNV with the OCTA?
Yeah, actually, I have the same question too. I wasn't 100% sure whether this decision is correct, but since I didn't see the increase of size in the neovascularization, and there's no fluid under the anatomy, under the infast OCT. So and then her the visual acuity remained stable. So that's the 3 reasons why I didn't give it an addition anti-VEGF.
Okay, only the size of the CNV that with the OCTA. How about the branching or how exuberate it's how density of the vessels, the OCT in OCTA. Did you?
Yeah, it's a little bit difficult to quantify, but just to measure by the size, I did not see the change in the branching network.
How about the density of the vessel?
It's almost the same. I mean, there might be a little bit error within each measurement, but generally speaking, it did not increase in size and density. Yeah.
Right. Thank you.
Great. Unfortunately, we have to move on to the next block because we are running over. So I'm going to hand off to Dr. Huang, and we're going to just continue here with a different set of panelists, and Dr. Huang will be leading now.
Thanks, Steve. It's my pleasure to introduce Dr. Kotaro Tsuboi, who's going to be speaking on longitudinal observation of retinal arterial macroaneurysms with OCT angiography. So, Dr. Tsuboi. You're muted, so if you can unmute.
Sorry, thank you for introduction. So what I'm going to talk about today is the cases with retinal arterial macroaneurysms. So retinal arterial macroaneurysms, RAMA, is acquired directions of the large arterioles of the retina, which lead to exudation and hemorrhage. Laser photocoagulation is currently the most commonly used treatment, and recently, anti-VEGF has been reported to be effective. The best approach to the management of RAMA is still controversial because RAMA can regress spontaneously. Further, laser photocoagulation can sometimes lead to severe complications, including BRAO. In this fundus photo, you can see subretinal. Here you can see RAMA along the supraarcade artery, and after photocoagulation, the subretinal fluid disappeared. However, OCTA shows BRAO. Therefore, in this case, it would be preferable to attempt minimally invasive treatment for RAMA. The advantage of OCTA is its non-invasive image modality. So I would like to show two cases with RAMA that were longitudinally followed up using OCTA. The first case was a 65-year-old female with a ruptured RAMA. Retinal hemorrhage and retinal edema were observed in the fundus photo and OCT. Along the supratemporal artery, we can see a white round region. So we diagnosed that the retinal hemorrhage was due to the ruptured RAMA and performed PVV in order to remove the hemorrhage. The following day after surgery, the retinal hemorrhage had been removed, but the retinal RAMA still showed reddish color, and subretinal fluid was also observed on OCT. OCTA showed a flow signal at the same location as the reddish region on the fundus photo. OCTA-B scan image also shows flow signal in the RAMA lumen. So we started cross-interval observation with OCTA in order to make a decision about treatment. So 5 days after the surgery, OCTA still shows flow signal, but the flow signal had regressed. 10 days after the surgery, flow signal was undetectable on OCTA, and fluorescein angiography also showed no flows in the RAMA lesion. Finally, in the fundus photo, we can see fibrotic change in the previously RAMA lesion. On OCTA, there was a small capillary dropout surrounding the region. Arterial flow recovered, but there still appeared to be some constriction. OCTA was useful to observe how RAMA regressed after a case of rupturing. No additional treatment was needed after the surgery. The second case was a 69-year-old female with exudative RAMA. At the initial visit, the fundus photo showed her exudation and retinal edema on OCT. On fluorescein angiography, hyperfluorescence indicating RAMA was observed along the superior arcade and also to lesser extent along the nasal-inferior. OCTA, we can see RAMA in both the unfast and B-scan image. To reduce the exudative change, we performed photocoagulation guided by OCTA in order to avoid BRAO. We performed a direct photocoagulation with the setting described in this slide. During photocoagulation, the flow signal in the rama was assessed using OCTA once the color in the rama changed from red to white. After 50 laser shots, the color in the rama turned white. So we performed OCTA, and OCTA also showed no flow signal in the rama immediately after the photocoagulation. Based on the OCTA result, we decided to end the treatment this session. 2 weeks after the initial treatment, the color in the rama was red on the fundus photo, and OCTA also showed a return of flow signal. So we performed the photocoagulation again, and this is after photocoagulation. This slide showed the longitudinal change in the flow signal in the rama. Flow signal gradually regressed, and finally, the original artery could be observed. This is the image at 3 months after the initial treatment. The area previously affected rama appeared to show fibrotic change, and original arterial flow could be observed. In summary, OCTA allows longitudinal observation that may help to make treatment decision. Rama assessment with OCTA during photocoagulation may be useful for treatment evaluation. So thank you for your attention.
Thank you. That's super interesting case. One question I had was whether the observation of flow signal within the aneurysm correlated with what you observed in the structural OCT for kind of exudative activity.
Thank you. It's a very good question. So actually, my observation on OCTA, like flow signal, is already disappeared. So the first flow signal disappeared, and then exudation or retinal hemorrhage gradually regressed. So this result may suggest OCTA is useful to evaluate the activity in rama.
I have a question, if I may.
Yeah.
So in the first case, when you have performed a tracheotomy in the patient, maybe I've missed, but have you performed a photocoagulation as well at that location, or not? Or have you done anti-VEGF or something like that, or steroid?
No, first case, we just performed PVD to remove retinal hemorrhage. We did not perform any additional treatment to rama.
Because I've noticed the improvement over time without doing anything.
No, so maybe I think first case, it's a spontaneously regressed case, so not necessary to treat anything, no additional treatment.
Very nice case.
Thank you.
I have some question, similar question. You treated only vitrectomy for the first case without the laser on macroaneurysm.
Yes.
Right? And in second
no
case,
additional.
Second case, you treated with laser. So how you decide laser or not laser for the macroaneurysm?
Thank you. So first case is already ruptured. So and after vitrectomy, we see some subretinal fluid at the fovea, and so we consider additional treatment if rama does not regress spontaneously. But fortunately, the rama regressed spontaneously, so we did not additional treatment. And second case is a treatment naive case, and exudation already reached to the fovea region. So we worried about the visual impairment due to severe macular edema. So we performed photocoagulation, but the location is very near to fovea, so we worried also about the BRAO and to reduce visual acuity after photocoagulation.
So I have another quick question. So in the second case, did you perform some kind of a titration on the edges of, on the edges of the lesion to see the intensity of the laser? Where you're, sometimes you're afraid of over treating and having a hemorrhage during the laser, so it's very dangerous. So did you perform a titration?
No, we did not titration. We only direct photocoagulation, and during photocoagulation after laser, we can see the color a little bit change. So I'm not sure what exactly happened in the Rama region, but after the 50 laser shots, we can see the flow regressed on OCTA. So yeah, so the direct photocoagulation can reduce the flow signal in the lumen, but I don't know the exact mechanism.
Thank you.
Thank you. Great case. We're going to move on to next presentation. Dr. Rui Hua, who's going to be presenting using OCTA to guide the treatment of pathological myopia patients with submacular hemorrhage.
Thank you very much for the invitation and introduction. I will share my slide. Good morning, ladies and gentlemen. And today my topic is about using OCTA to guide treatment of pathological myopia patients with subretinal hemorrhage. I'm Rui Hua from China Medical University. And as we know, the myopic micropathies will include the lateral crack or the dystrophy or the subphthalmoma and the subretinal fluid and CNV. The CNV is a significant cause of the vision impairment in Asian countries. And subretinal hemorrhage is very common in CNV. And also peak rated CNV also can lead to the subretinal hemorrhage in myopic eyes. Let's come to the first case. It's 22 years old female with the broad regions and with blood spots in her left eye and with decreases of BCVA in the left eye and the normal intraocular pressures and arterial segment examination. Let's come to the multicolor image. We will find in the left eye there was a subretinal hemorrhage here. And then we performed the fluorescein graphics, ICG angiographies, and this is the right eye from the early stage to the late stage, and this is the left eye. We will see the bulk is fluorescein in the macular region here, and from the early stage to the later stage, also the bulk is fluorescein. And at the late stage of the ICG angiography, we will find there was a lateral crack. Here is lateral crack. And from the OCT image, we find we confirm the subretinal hemorrhage, and this hemorrhage were related to the lateral crack. And we just performed the oral medication treatment, and the subretinal hemorrhage were observed finally. And this is the macular color image at the last visit. Here, this is the first case. Let's come to the second case. It's also a young lady with binocular high myopia and report broad visions in her left eye and the reduction of the BCVA in her left eye here, and also with a normal intraocular pressures and arterial segment examination. And she was alert to the fluorescein and only received ICG angiography. Let's come to the color founders image. For the right eye, we find the lateral crack here in the macular region, and in the left eye, we find the subretinal hemorrhage here and with the subretinal fluid here. And we performed the ICG angiographies. We find here in the later stage, we confirm the lateral crack here. And for the left eye, we find there was the dark lesion here within the macular region. From the early stage to the later stage, there were also a small dark lesion, a round dark lesion here. But for the right eye, this is the right eye OCT image, and this is the left eye. we found the fibrovascular exudation under the retina here. No any signs of the CNV, pathological CNVs in the ICG angiography. And then we perform the OCTA. Okay, well, we find the following signals of the CNV in the macular region. So we perform the anti-Vegf therapy, and we find the strategies of the CNV at each follow-up. And at last follow-up, we found there was also a dark lesion here. What about this one? Is a CNV? So we come to the baseline. The same locations we find there was a turbulence RPE lesion here. And after the anti-Vegf section, anti-Vegf treatment, we found there was the iso-refractive lesions in the outer retinal layers here. So we diagnosed the case as for this stage, it's a stage 3 PP with CNV. So at baseline, the lesion is here. So the difference for the two cases describe the difference of the different mechanism cause the subretinal hemorrhage in the macular in the myopia to diagnosis, because some of which do not require the anti-Vegf therapy. And OCTA is an invariable tools in diagnosis of the myopic subretinal hemorrhage and differential the inflammatory receiving from the inflammatory lesions. Thank you very much for listening.
Thank you. That was a fantastic presentation. My question for you was, if you have a myopic patient that presents with submacular hemorrhage these days, would you consider just getting an OCTA and foregoing ICG or FA?
I think good questions. I think OCTA is effective to detect the CNV in this kind of case, but we also will perform the angiographies to see the linkage from the lesion, and we just to find if there are any inflammatory factors for this kind of CNV, because there was overlapping with the myopic CNV and the inflammatory CNV. So we will perform the combined use the OCTA and the angiographies to detect to diagnose this lesion. Thank you.
Ray, very good case. For me, if I want to differentiate CNV, I would choose to use OCTA first. I mean, to rule out the CNV, because in your case you did multimodal imaging, which is nice. But just for differentiation, I mean, for CNV, we probably can use OCTA first.
Thank you very much for your comments.
Thank you very much. Thank you. We'll move to the next case. Next speaker is Dr. Qisheng You, who will present on OCTA detected non-exudative CNV, indicates a closer monitoring in age-related macular degeneration. So.
Thank you, Dr. Wang, for your introduction. Good morning and good afternoon, depends where you are. So this is a 78-year-old woman presented with blurred and distorted vision in the left eye for 3 months. Her vision was 20/25 in the right eye and 20/60 in the left eye. On dilated fundus examination, we can see some Jiuan and peak interchange in the right macula. In the left macula, we can see a gray lesion in the left eye. Fluorescent angiography showed some a small window defect and maybe some staining of the Jiuan in the right eye. In the left eye, there is a strong leakage. And structural OCT showed small Jiuan in the right eye and subretinal hyperrefractive material and subretinal fluid in the left eye. The central macular thickness of the left eye is 540 micron. The OCTA of the left eye confirmed a prominent CNV in the left eye. And interestingly, in the right eye, in the location of the Jiuan, we see some flow signal on the OCTA-B scans. On the on-fast image of the outer retinal plexus, we can see the small area of the CNV. So this patient was diagnosed with exudative AMD in the left eye and non-exudative AMD in the right eye. And she was treated with Avastin for every 4 weeks for the left eye and followed monthly for both eyes. At the 4-month follow-up visit, she complained the vision drop in the right eye for 1 week, and structural OCT show newly developed subretinal fluid. And the left eye is drying up. Also in the right eye, we can see some subretinal hyperrefractive material as well. The OCTA in the right eye demonstrated 2 separate CNVs. The one detected at the baseline in the nasal inferior location and grow in size, and there is a new one developed in the detected in the temporal superior. And the OCTA of the left eye showed the CNV size decrease after treatment. So OCTA detected non-exudative CNV was initially reported by Dr. Bailey's group in 2015, and also later by Dr. Rosenfield's group as well. In the recent paper by Dr. Bailey's group, the 8 out of the 10 eyes with non-exudative CNV developed exudation within 2 years of follow-up, and 6 of the 8 eyes developed exudation within 1 year, actually. Usually, before the developing of the exudation, the CNV size increase, and with treatment, OCTA can show the CNV size decrease. And the Kaplan-Meier regression analysis demonstrated that the risk for developing exudation in eyes with non-exudative CNV was 18 times higher than the eyes without non-exudative CNV. Similar result was also reported by Dr. Rosenfield's group. So the take-home message I learned from this case and also the related literature is that OCTA detected non-exudative CNV may be a precursor of exudative CNV, carrying a high risk of developing exudation within 1 year, and may benefit from close monitoring because the exudation can develop actually as short as 1 month after detection. And neovascular AMD used to be interchangeable term with the exudative AMD, but now OCTA told us the neovascular AMD should be classified into exudative neovascular AMD and non-exudative neovascular AMD. This is the OCTA really told us and really helped us, gave us new knowledge of this very important blindness leading disease. Thank you.
Great presentation. Thank you so much. I have one question, and there's another question from the audience. Actually, it's a question for the whole panel, if I can ask. How often do you always get OCTA on patients presenting with unilateral exudative AMD? And how often should we be getting OCTA on either intermediate AMD or unilateral exudative AMD patients?
In my personal opinion, I think for every patient with unilateral AMD, we should perform OCT for both eyes, because in the case study and in other large studies, it shows that almost 20% of the eyes will develop exudation in the fellow eye in patient with one eye with the exudative AMD.
Practically speaking, how should we be getting OCTA every 3 months on those patients, or every time we see them?
Yeah, that's a good question. I think at least we need a structure OCT. If the structure OCTs give us some hint, there may be OCT, there may be like a double layer sign, or there may be something under the RPE, then I think the OCTA is indicated. For every 3 months with the OCTA, practically, I think it may be difficult because it's time costing.
Yeah, that's the same questions I have. Based on the the papers that you showed on Rosenfeld's experience and also Stephen Bailey's experience, were you able to match some kind of a protocol to follow up this patient? Do you have an idea of well, you know all the signs that we already know it, but do you have any idea based on these papers published?
Yeah, I can.
Your experience.
I can answer a bit. So in
Steven,
our initial protocol was a prospective study, and those patients had an OCTA every 6 months. So that was the frequency for OCTA. And in those cases, I think we picked up about 12% of the fellow eyes with CNV. Those are the eyes that were scanned every 6 months, had a CNV that we otherwise would not have detected. So that allowed us to follow those eyes closer than we may have otherwise. And that was we followed it with monthly OCTAs. Part of the study, we're looking for growth for other biomarkers, but I think a structural OCT would be just as useful because we're basically treating exudation, right? We're doing a second study now where we're actually prospectively following and getting OCT every 3 months to see if that might help us identify those few patients who converted within the 6 month range. So we may be able to catch a few of those earlier. So that's kind of our study. That's our study, which was admittedly we had only 10 eyes. So,
Stephen, were you also able to find some kind of biomarker for patients that evolved with GA?
No, we didn't have we don't think there's a direct association with that, but it's hard to know. And so that's the big argument, should we treat or not? Because there's a worry that these lesions prematurely may, affect geographic atrophy. And so that's a harder question to answer. And it's more of all the evidence is still pretty anecdotal, to be honest. And so, but I think you can't go wrong if you just have frequent OCTs looking for exudation when you see them. Most of our eyes converted, and actually one of the two that hadn't converted now did convert 5 years later. So we're actually at 90% conversion, for our study. So if you follow them long enough, I think these eyes have a high risk for converting. So.
Thanks.
Thank you. I'm going to hold the questions that we have till the end because it's more of a general question about OCTA, and I'm going to introduce our next speaker, Dr. Joseph Simonet, our former resident, and he's going to be talking about a bumpy road.
Great, thanks, Thomas. It's great to see everyone. This is almost as good as being back in Portland. I'm one of the retina fellows now out at the University of Utah. And this is a picture of me trying to keep up with my wife, which is my usual situation now out here in Salt Lake. Let's see. So this is a case of a 40-year-old man with a history of pseudoxanthoma elasticum and no visual complaints at this time. You can see some of the classic findings of these angioid streaks, both around the nerve and radial through the macula. And many of these streaks also extend out into the periphery. While he was asymptomatic at this point, not too much longer after these pictures were taken, he was in a relatively minor car accident after which he reported vision loss in both eyes. We saw him in clinic a couple weeks later, where these photos show bilateral and pretty diffuse choroidal ruptures and subretinal hemorrhages in both eyes. This is also seen on structural OCT, showing the subretinal hemorrhage here. And then also these kind of fracture lines along the RP and Brooks membrane complex. So at this point, he was observed, and he got better as subretinal hemorrhage started to resolve over the following months, and he improved all the way to 20/80. But then he got worse, dropped to 21/50 with a subjective visual decline in the left eye. And here you can see a few things. You can see some increased subretinal hyperreflective material. You still see the persistence of these fractures through the kind of the RP and Brooks membrane. And then there is this new hyporeflective space. But I think at least on these scans, it's a little unclear to me whether this represents fluid from secondary CNV or if this is some type of degenerative or cystic change just due to these abnormal and large fractures through the RP and inner choroid. And even with the fluorescein, I think the picture is still a little unclear. We see some signals of leakage here, but I think even months down the road, we may expect some leakage from choroidal rupture sites, just given the exposure of the choroid and choriocapillaris in these areas. So like many other cases today, I think OCTA really helps us define the anatomy and pathology in this case, which shows a pretty definitive choroidal neovascularization above the RP and into the subretinal space. So in this case, it was really this modality which I think made us most confident in proceeding with anti-VEGF treatment, for which he got a series. And this is just a reminder of what he looked like beforehand. He had a really nice response, improved to 20/30 in this eye. You can see a reduction in volume in that subretinal hyperreflective material. There is still some persistent intraretinal fluid, but this improvement seems to have allowed him to have a lot of improvement in his ellipsoid zone right at the fovea. That probably explains a lot of his improved visual acuity. So just a few very basic takeaways from this case. Patients with pseudoxanthoma elasticum are at risk for choroidal rupture due to the calcification and fragility of Brooks membrane. Patients with choroidal rupture are at risk for secondary CNV. And OCTA seems to be particularly helpful in defining the anatomy and guiding treatment in these patients, often when you expect persistent leakage on FA because of their traumatic injury. So that's it. Thanks for having me. Happy to answer any questions.
Thank you. That was a fantastic case. I feel like we should get a bubble wrap for all our pseudoxanthoma elasticum patients.
That's right.
There's a question. Steve, do you want to just ask that?
Yeah. Joe, was there a direct eye injury during the crash, or was this just like a counter coup?
Yeah, it was just kind of like a whiplash injury. He really had no other significant injuries from this accident. I don't believe he required hospital admission. So it seemed like a relatively mild injury that people with normal eyes probably would not have this type of reaction to.
Dr. Romano?
Yeah, very, very impressive case, Joseph. It really impressed me. I mean, 20/30 at the end, it's an amazing outcome. But what I really want to know is that, are you able to perform microperimetry in this case? It would be very interesting to find out the areas where have the lesion, that the vision preserved.
Mm-hmm.
And, do you have access to it?
Yeah, we have not in this case. We do have access to microperimetry here. So that's something we could do. But yeah, I totally agree with you. I think he's just lucky that he didn't happen to rupture right through the fovea, and he probably still doesn't see very well in the sites that he did. But yeah, it'd be really interesting to see how that maps onto his structural and OCT and OCTA.
Yeah, because there's some areas that you show on the left lower. You see a collapse of the ellipsoid zone there, and it may lead to an atrophy there. And it would be very interesting to see the microperimetry map, or if you don't, you mentioned you have it, or a visual 10-2 visual field also could contribute a little bit, but microperimetry is way much better. It would be very interesting to find out, you know, the whole picture of this fundus.
Yeah, I think that's a great idea. I'll suggest that when he comes back.
Dr. Hsieh?
Yeah, hi Joseph, thank you for your interesting case. Actually, I have seen a similar case, and the OCTA showed perfect new vessels. In the case with, in my case, it is not pseudoelastic, then somaelastic is a traumatic choroidal rupture. And after the Anti-Vegf treatment, actually the vessel, they did not go away, they become more mature. And I also have observed in some cases of traumatic choroidal rupture, we can see the new vessels, the abnormal new vessels from the OCTA, but they did not leak or do any harmful things. And I'm thinking maybe during the repair process of choroidal rupture, there is always some new vessels. But do you think that we can differentiate the benign new vessel or malignant new vessels from the OCTA?
Mm-hmm. Yeah, I think that's a really good question. I certainly don't have a good way to do that. And it's kind of shameful that I don't have a follow-up OCTA, unfortunately, in this patient. We'll have to get that as well to see if those vessels have regressed significantly. Because I think you're right. I think at least some of them will probably be persistent. But no, I can't think of a great way of how to differentiate without treating them and seeing how they respond, whether they're pathologic or just not a problem.
So there's no follow-up. That was one of the questions from Dr. Luhan, whether the OCTA on follow-up showed regression of the vessels or not. So.
Yeah, unfortunately, we don't have one. He was supposed to get it at his last visit, but something happened, and we don't have that yet. But he should be coming back soon.
Great. Thank you. Thanks for the great case. One more question I have for the panelists is, you know, there are some textbooks that say, you know, for pseudoxanthoma elasticum patients, you shouldn't even do scleral depression because they are prone to these injuries. What do you say to your patients that have this underlying condition about precautions that they should take? I'm going to take the awkward silence to mean that we don't have a standard way that we talk to our patients about that. But it'd be, yeah, if you have thoughts, I would love to hear about it later. I'm going to introduce our last presenter, and we'll have some time for final discussion after that. Dr. Miho Nozaki is going to be talking about detecting CNV by OCTA.
Thank you. So can you see my slides?
Yes, looks great.
Thank you. Good morning and good evening, everyone. I'm very happy to be here. And it's very informative and wonderful case presentations. And I'd like to share the situation in Japan at first. So under instruction by Professor Ogura, Professor Sakamoto, and Professor Ida, we have conducted multi-institutional prospective study, and we have shown that OCTA is non-inferior to FA in sensitivity of detecting the lesions. And OCTA is covered by health insurance from April 2018. And I had a small survey among Japanese ophthalmologists in last year and 2 years ago. And this is the question from the previous PAT survey. And in 2019, 93% of doctors are negative for OCTA, but 2020, almost 90% are positive for OCT angiography. And this is the OCTA machine we are using. And these are just for your information. and asked the question that what kind of diseases do you really appreciate if you have OCT-AR? And the number one is not disease, but condition. If the patient is pregnant or allergy to fluorescein angiography. And I regret to put so many choices in these questions, but it looks like detecting choroidal neovascularization is the second advantage from OCT angiography. As you know, from these today's conference, 80% are talking about CNV and 20% are about retinal vascular diseases. And actually, this is the first case I really appreciate OCT angiography. And she was diagnosed as mute, and she was followed without any medication. But 1 month later, her vision deteriorated. And there's a subretinal fluid and intraretinal fluid. And we did fluorescein and ICGA, but there's no confidence to if she had CNV, but OCTA clearly showed CNV, and we gave her anti-VEGF injection. And also, like non-exudative CNV in fellow eye AMD, this is our case, please, and we have found that 24% had quiescent asymptomatic CNVs were detected only by OCTA. And not only fellow eye AMD, as you know from today's conference, from inflammatory diseases, they have CNV, and it's really easy to detecting CNV if you have OCT angiography. This is the case of Pick, and he also had myopia, and he complained about photopsia in his right eye. And compared to dye-based angiography, we can see CNV very clearly. And later, his vision deteriorated, and he was treated by anti-VEGF and steroid. And this is another case of Muse. She was diagnosed as Muse 8 years ago, and she was treated by systemic steroid. And last February, she came back to my clinic, and she complained about metamorphopsia in her left eye. And she was told that she should get vitrectomy because she had a epiretinal membrane from her local doctor. And actually, in the OCT scan in 2020, there's a epiretinal membrane, but also there's some subretinal fibrin-like material. So we did not do dye-based angiography, but we just do OCT angiography, and we have found that the CNV developed. So we gave her anti-VEGF injection, and she didn't come back to University Hospital due to COVID-19 virus situation. But 5 months after anti-VEGF injection, she came back to my clinic, and her vision improved. There is some CNV structures, but symptom disappeared, so we just keep watching her. And this is the last case, and he has a POAG, and he complained about relative central scotoma in his left eye, and his IOP was well controlled, and his vision was 20/20. He had advanced glaucoma in his in visual field result, and there's a RP irregularity in OCT scan, and we have found that CNV in OCT angiography. I keep watching him by 3 months using OCT angiography, but I also measure the CNV flow size, and I hope that if there's a kind of auto system to measure the CNV size in OCT angiography, that's my hope. And I want to ask the panels, how would you follow him later? And in summary, for detecting CNV, OCTA might be better than FA and ICGA, and OCTA useful in making the diagnosis of CNV in daily clinical practice. And last but not least, Professor Ogura will organize the second International Ocular Circulation Society meeting in Kyoto. So hopefully see you in Kyoto. And thank you very much for your attention.
Thank you. That was a fantastic talk. It's exciting to see that Japan is ahead of United States in recognizing OCTA as a valuable service in addition to structural OCT that probably has helped advance the field more and patients get better care because of that. That's wonderful. One of the questions from the audience earlier was limitations of OCT and what OCTA measurements are necessary. Your presentation was a perfect answer. You mentioned the size of CNV as being a key metric that we need. What other challenges have you encountered, and what improvements need to be made in OCTA to make it more useful clinically?
So sometimes there's a segmentation error occurred. So if we can manage very easily, yeah, it will be better to diagnose more precisely and correctly.
So more reliable segmentation, particularly probably of the outer retinal slab. Yes. Another question from the audience was that it's not always easy to get a very clear image of the vascular structure. And Dr. Sharma was interested in if you used a built-in software or it was a custom software that you were just demonstrating.
I use custom software and mainly Avanti and sometimes Triton from Topcon. Yeah.
And you had a question for the panel, right? And
yeah.
To restate that.
Yeah. So I keep watching non-exudative CNV every 3 months using OCT Angiography, and I measure the CNV size. But is it necessary to measure the size or just see the B scan? And what do you think about that? How to follow them?
Yeah, I would think it's worth measuring the size of the CNV if you have a good tracking system, because it's important to have the same location and the tracking is more important.
Thank you.
Can I have a question?
Yes.
Yeah. What about the important signs for the non-excessive CNV regards to the excessive CNV on OCTA?
Excuse me, could you say again?
I mean, in Dr. Bailey's paper, it shows that usually before the conversion to the exudation, usually the size of the CNV increases. So again, just like we discussed just now, the measurement of the size may be helpful. If you see the CNV size increase, then it may predict the exudation. And then of course, the direct sign of the exudation is the fluid.
Thank you very much. There were so many parameters for monitor the CNV. Maybe the ending point density and the capillary density and the joint density. So there will be a guideline for treat or for monitor the CNV from the non-excessive to the excessive type. Thank you.
I see. Thank you.
Great point. Thank you.
Dr. Lin?
Yes, can I have a question to Dr. Yu and also the rest of the panelists? So does anyone suggest any follow-up protocols in patients with pachychoroid disease or in high myopic patients when they have a unilateral CNV? Do we routinely follow up the fellow eye with OCTA as well?
That's a great question. I don't have much experience on that, but I think since the OCT and OCTA scan is really fast and non-invasive, it will be useful and helpful for clinical decision just to monitor the fellow eye, since the fellow eye always have a higher risk than the general population to have a CNV.
Yeah. So do you suggest 6 months as well?
It really depends on the disease. I think, like in the AMD, it can convert to the exudation from non-exudative status within 1 month to 14 months. So I think every 6 months may be a little bit too long. Every 3 months would be safer.
Yeah, and then further question. So does the in AMD cases, does the fellow eye's status difference regarding the follow-up time for OCTA? For example, if it already has an intermediate dry AMD, or we just have a little bit early drusen in the fellow eye, does it matter whether you decide to do OCTA for the fellow eye?
Yeah, if one eye has CNV, then the fellow eye is at high risk. So if they have that, then I typically would get OCTA every 3 or 6 months. If it looks like there's more drusen or more disease, then maybe 3 months would be better, but that's more just anecdotal and preference, not really evidence-based. It's hard to know if this same study would be analogous to myopic CNV. I don't know off the top of my head if myopic CNV in the fellow eye rates are as high as they are in AMD. And so, maybe 6 months is reasonable. We also know myopic CNV tends to be a type 2 CNV that might sprout up quicker. Oftentimes, the non-exudative CNV are these more typical AMD type lesions. So I'm not sure if it's entirely analogous to compare that study to myopic CNV.
How about for pachychoroid diseases? What do you think?
So pachychoroid would probably be more analogous because you're more likely to see, a type 1 CNV. And then I would monitor for those for exudation. Interestingly, those tend to be less aggressive. Those are more mature lesions. They kind of have a little fluid, and you're less likely to get a massive hemorrhage, for example. But it's useful to identify the CNV, so you're going to watch you'll be more reactive to exudation if there's CNV versus a case of CSR, for example, in terms of how you would approach it.
Thank you.
Dr. David Hwang had a question for the panel. Do you want to ask it, David? Or I can.
Oh, sure. I was just very happy to hear from Dr. Nozaki that OCTA has its own reimbursement code in Japan. I wonder if the other panelists can comment on how OCTA is reimbursed in their country, whether it's more like fluorescein angiography or more like structural OCT, whether it's got its own reimbursement code.
Can I speak first?
We have, sorry.
Sorry, please go ahead.
Thank you. We have our insurance to cover the OCTA. It's like 190 Chinese yuan in my city. So if the patient has insurance, the insurance company can cover the OCTA.
Yes, in Taiwan, it's about the same price as OCT. But if you want to apply for a reimbursement for the AMD or DME, and you can prove that the patient have a poor kidney function, then you can skip with FN. You can just present the OCTA.
In Japan, Dr. Nozaki told that we got the reimbursement, but we have the still limitation. They allow just every 3 months, not every month. it's the very on the clinical, we want to use the every month or every visit, but they don't allow the every month requirement.
And OCTA is higher than OCT, regular OCT, but you can't charge to both examination at the same time. You have to choose. And the disease are limited only for AMD, DME, and retinal vein occlusion, and glaucoma. I think.
Thank you.
Very interesting.
I wanted to give the panelists one more chance to kind of bring up some, this was a fantastic presentations with a lot of victories for OCTA. And Yali Jia asked what are some challenges that we need to meet with OCTA? What are some improvements that you want to see happen? So Dr. Nozaki pointed out the measurement of CNV as a improvement that we could make. Any of the other panelists have some thoughts about that, and we can maybe end with that question.
Yeah, for example, is wider field more important, or higher resolution, or deeper penetration, or other?
I think one thing might be really useful is some sort of autofocus that would really focus in on the retinal vessels so we could get consistent, sharp images. And then that would make it more useful to follow those up over time. Because a lot of the quantitative data is really influenced by the image quality. So that would be something that would be, really important, especially for the macular disease.
So the platform have to improve their focusing functions, higher transverse resolution.
Yeah.
Yeah, that's right.
Can I share
Also,
can I share
sorry,
my the PowerPoint? We have just the Canon released the wide angle just the wide angle OCTA. This one is the 23 by 23 millimeter. It's very useful to detect the.
Can you open up the slide? Can you increase the?
Oh, could you tell me again?
Can you increase the slide? I mean, just put it in a presentation mode so we can take a peek at the image quality.
Can I share? Oh no. Oh, sorry,
yeah.
スライドショーモードにしてください。スライドショーモードになってないから。
なっていない。なっていない。こっちではなってるんですけども、どうしよう。スライドショー。Just a moment. Okay. I'll try again. Sorry. スライドショーになっていない。So is that okay?
Yeah.
Good.
So we just the Canon released the 20 by 23 millimeter wide angle CTA. We just purchased last week, and we took the several pictures, and also this one has an advantage of the wide angle. It's very useful to detect the CNV or non-partition area in especially the diabetic retinopathy, or that today there are many doctors that present about uveitis. You can detect some change in peripheral area. Also, that this machine has AI higher resolution. I compared the 6 by 6 millimeter image or Canon and OptiView. You can see the higher resolution in Canon, and also that this machine has an advantage with scan speed. This is a SSOCT, so just scan speed is 11 seconds, but OptiView has 25 seconds. So, and also this is a normal volunteer, and this is a BLA of patients. That you can see the better image of the better image. And Canon has only the one scan, and the AI improved the image, the resolution. So I think the technology development is very useful to our clinical work. Thank you for
Dr. Kamei,
Yes.
for that wide angle image,
Yes.
Is it a mosaic image or it's a
No,
one-shot image?
Just one scan.
Oh, great. Because I'm using Canon demo machine in my clinic. I didn't get this software yet.
How
Maybe
long
this
does
is
it take?
Japan.
Yeah, this is a new machine. It's
Okay.
small. Yeah.
That's beautiful.
Moto, how long does it take to get this 23 millimeter scan?
It takes a little bit longer. Just 1 minute, a little more.
One minute?
Yeah.
Oh, so it's tracking all the time, of course.
Yes.
Yeah.
Yes.
I see.
Okay.
Wonderful.
Thank you. On behalf of Steve and I want to just thank all the presenters and the panelists and all the attendees for being here. So I learned a lot, and it was fantastic, fantastic evening / morning. Thanks for being here on a weekend. Hope to see you again at our next meeting.
Yeah. Hope we can go to Nagoya.
No, in Kyoto.
Hope we can go anywhere.
Thank you.
Thank you.
Thank you.
Thank you.
I'll see you in Kyoto.
Yeah,
See you.
See you in Kyoto.
See you in Kyoto.
Thank you.
Thank you and see you.
See you.